Minity, you're still, it says you're sharing yours. No, that is Jolly. Okay, that's fine, Jolly. Minity, you're still, it says you're sharing yours. No, that is Jolly. Okay, that's fine, Jolly. Good morning, everyone. Let me just share the link with our group, and then I will we can start the session. There's does actually, I think, make it a little tedious to be doing that. Yeah, I've shared the link on the group now. So good morning, everyone, and welcome to the Pediatric Symposium IX. This is one of the first of our academic activity on the group. I'm getting a okay. Yeah, and a very happy New Year to all the members. So I mean, it's been a great journey for coming to the 9th Pediatric Symposium. And when we started off, we used to actually have around 4 or 5 topics, but we now restrict to around 3 to 4 topics so that we have better discussion. People don't get bored. And today we have 3 great speakers. I would be handing over to Jody to introduce the speakers and the topics. So over to you, Jody. I need to unmute. Yeah.
Can you hear me now?
Yep.
Okay, thanks, Shiv. So as Shiv said, welcome everyone. We will moving forward with this new year with another 3 sets of talks. Our first speaker is Dr. Meenati Chaudhary. She's the professor in the Cardiac Anesthesia and Critical Care Division of the All India Institute of Medical Sciences, New Delhi. Her special interest includes cardiac anesthesia, medical education research, critical care, and echocardiography. She completed a MBBS from BHU, and she's a postgraduate diploma from the All India Institute of Medical Sciences. She will be talking to us about children with uncorrected VSD and ASD present for non-cardiac surgery and their anesthetic consideration. Thank you. It's to you, Dr. Meenati. I'm going to unshare my screen.
Jody.
Yeah.
I think we're still 3 minutes, I think, ahead of the thing. So could we just actually do the introductions of the rest of the faculty as well, and
yeah,
start off here? Is it okay, Minati? Can we just
should I stop sharing?
Yeah, stop sharing. Let I think Jody introduce and the other speakers as well. Jody, you're going to introduce yourself as well.
That's okay.
You can start off introducing yourself. Because we do actually have new members who are actually attending. I think Minati is still sharing her. I think Minute, you're still sharing your screen. Can you stop sharing your screen for a minute, please? Yeah.
Okay.
Yeah.
Okay.
Yeah. You can try now. Yeah.
You can see the screen.
Yeah, but it's showing your folder.
Oh,
Yeah, you haven't opened the PowerPoint yet. Yeah, no, I think no, gone off. It's gone off.
yeah, I can see, but
Yeah, so you are only sharing your. Yeah, I think click that on that again.
I got it now. It wasn't coming up. It should come up now.
Yeah, it is. It is now. Yeah.
And following Dr. Minati's presentation, I will talk about craniosynostosis repair in children. One of the staff anesthesiologists here at the Hospital Sick Children in Toronto, Ontario, Canada. And our third speaker is Dr. Senthil Bhakesababavi. He's an assistant professor of clinical anesthesia from Indiana University School of Medicine. He completed an anesthesia residency from All India Institute, and he's also completed his fellowship from Riley Children Hospital Children in Indianapolis. His special interests are pediatric anesthesia, acute pain, pediatric pharmacogenomics, and pediatric transplant anesthesia. So we welcome Senthil. This is going to be his first talk, actual talk with our group, but he's a very widely published researcher, and he has contributed to our discussions in the past. So we're very much looking forward to his talk as well today. So with that introduction, I'm going to hand over, stop sharing, and let Dr. Minati share her screen and start her talk. Thank you.
Thank you, Jadi.
Webinar.
So I have to wait.
Yeah, Minute, you can start. Yeah, we're fine with the time now. Yeah.
Okay. Thank you, Dr. Siv and the entire team, Jadi, Senthil, everyone. And in the next couple of minutes, we are going to discuss about a child with uncorrected AST or VST, which posted for non-cardiac surgery. What are the anesthetic implications for such a case? So it is very important to know the hemodynamic and clinical manifestation and associated anomalies what are associated with these congenital cardiac defects, because these are also important when the child is undergoing any anesthesia procedure, whether it is regional and whether it is GA. So the first of all, we should know regarding the defect. Come to the AST. What is AST? There is a defect in the intra-arterial septum. This is the transesophageal echocardiography image of a child with a secondum arterial defect. And you can see the right atrium, left atrium, and there is a defect in between from which left to right shunting can occur. So this is another child with having a big, you can see this entire chamber is atrium. There is the absence of the entire septum. This is common atrium type of AST. So AST is divided into different type depending upon the position to the fossa ovalis. Why it is important? Because different ASTs are associated with different congenital anomaly. So that's the reason they are important, and they have different manifestation if they are severe in the intraoperative period. So one is sinus venosus type. It is either SBC or IVC type when they are situated near the SBC or IVC. One is ostium primum type when it is situated near the valve and at the lower part of the intra-arterial septum, and ostium secundum, and there it is near the fossa ovalis. One is en route coronary sinus. And as you can see, the ostium secundum AST is primarily associated with Holt-Oram-Treacher-Collins syndrome, ostium primum with Round syndrome, sinus venosus with Noonan syndrome, and common atrial type with Ellis-Van Creveld syndrome and asplenia. So when the echo report shows this kind of defect, at times you should look for some possibility of these syndromes, because all these syndromes have anesthesia implication. So next is important is what is the pathophysiology. As you can see, there is a defect in the atrial septum. So all the blood from the left atrium, when it is unrestricted, go to the right atrium. So right atrium is getting blood from three places, from the SBC, IVC, and all this. So right atrial chamber is enlarged. So all this blood now, they go to the right ventricle. So right ventricle is also getting volume overloaded. So this double blood is again going to the pulmonary artery. So that means there is in the course of time, because the pulmonary system is compliant, so there is increase in the pulmonary capacity, there is increase in the size of the pulmonary artery. But in the subsequent stage, when there is a development of the pulmonary vascular disease due to the chronic pressure overload, there is a reversal of the shunt in the opposite side. So the shunting will go back and it will again from right to left side. And in this condition, the child develops cyanosis. So in the severe condition, again, child may have some grade of tricuspid regurgitation, because there is increase in the right-sided pressure and the backflow. So the entire clinical picture of the AST depend upon the what is the size of the defect, what is the magnitude of the shunt, and what is the systemic and the pulmonary vascular resistance. And in the minor case, there is the child may not have any symptom, and there may be mild right side enlargement. The child may present with the right bundle branch block or right atrial enlargement simply. Or if the size is very massive, the child may land up in congestive, maybe have features of congestive cardiac failure, especially in case of the very large defect. So the child may have pulmonary edema or recurrent respiratory tract infection, and there may be mid-diastolic murmur, and ECG may change prolonged PER interval. There may be right bundle branch block. There may be evidence of arterial arrhythmia. Similarly, if there is excess blood flow, there may be changes in the pulmonary vascular bed. There is development of the cyanosis, there is fixed split, and there is mid-systolic ejection murmur. And this child in the subsequent stage may develop cyanosis. ECG finding is important, because from this, these are specific for some specific kind of defect. And most of the AST, they have right side enlargement and right axis deviation. But however, the child with ostium primum AST, they have the left axis deviation and RDSR pattern in the ECG. So this is important, because ostium secundum AST especially present with atrial flutter and fibrillation during the intraoperative period. There is right bundle branch block because of the right sided chamber enlargement, but this is not that significance for the intraoperative management. But whatever significant is, that is AF and atrial flutter. Similarly, if there is ostium primum AST, the child may have first degree heart block. If you don't examine the child also, if you can see the ECG and you know the echo finding, there is possibility if there is a left axis deviation, that means the child has first degree heart block. And especially in case of major surgery, one has to be careful with a temporary pacemaker ready, because intermittent block can happen. If there is sinus venosus AST, this child may undergo junctional rhythm during intra period. Chest X-ray, I'm not going to detail, and this depends upon the size of chamber, different stage of the disease, and development of the pulmonary artery hypertension. Echo, again, pre-op echo is important. One should know how to read the echo, especially the transthoracic echocardiography. At least you should remember the finding, because each finding is important. The type of defect, you have to see the size of defect. And if the size of defect is small, it doesn't matter much. But if the size of defect is more than 6.5 mm, that means this child may have problem during the intraoperative period. Similarly, the direction of the shunt, and you have to look for the evidence of the shunt reversal. Shunt fraction is again important. If the QP/QS is less than 2.1, it doesn't matter. But if it's more than 2.1, so you have to ready with some vasodilators and ready with further intraop mishap, especially if the child is undergoing in major surgery. Similarly, you have to look for the what is the chamber size of the right atrial chamber and what are the left atrial chamber. Left atrial chamber enlarges means the child is having more problem if only single right atrial chamber is enlarged. massive right atrial size denotes that these cases may landed up in intraoperative atrial fibrillation, and also echo shows the ventricular dysfunction. Cardiac cath usually not required in case of the AST. Now look for the VST. If you look at the ventricular septum, it has a different part. One is a membranous septum that is very small, and rest is the large muscular portion. And this muscular portion is divided into inlet septum, that's trabecular septum, and the outlet septum. This zone is important to know because there are different type of AST depending upon the anatomical situation. So they are divided into 1 to 4 type. Perimembranous, which is around the membranous septum, that is more important, and that accounts for the maximum type of AST, that accounts for the 80% of the cases. And if it is outlet AST, there is some pulmonary valve abnormality like pulmonary stenosis, and you have to be careful during anesthesia management. Similarly, if there is inlet VST, there may be some tricuspid valve abnormality, and there might be muscular VST. Muscular VST, most of the time, they intend to close if they're small, especially between 3 mm to 3.5 mm. And if it is more than 6 mm, then you have to be careful. Then type of the pressure, it is also important. You can define what is restrictive, what is moderately restrictive, and what is non-restrictive VST. Restrictive and moderately restrictive VST, the QP-QS ratio is small, that vary from 1.4:1 to 2.2:1. So that doesn't cause much problem in minor surgical procedure. But however, if the AST is non-restrictive, if the QP-QS ratio is more than 2.2:1, that means it is problematic during the intraoperative period. Next, coming to the pathophysiology, if you can see, like the AST, in the VST, there is a septal defect. So entire blood from the left atrium goes to the left ventricle and to the pulmonary circulation. So pulmonary circulation is getting double blood from the right ventricle as well as from the left ventricle. So the entire circulation is again going to the pulmonary circulation. So that means left atrium is again getting double blood. So double blood is by the receiver chambers are the left atrium, left ventricle, and the pulmonary vasculature. So there is left side enlargement is much more than the right side enlargement in AST. So again, the clinical feature, it depends upon the pathophysiology. So I'm not going to detail regarding the clinical feature, but however, if the small AST, they have high resistance to flow and they have less than 50% ventricular output, this child doesn't matter much in the childhood. They don't cause so much of anesthesia problem, but however, in the subsequent stage, maybe 15 to 20-year age, they develop pulmonary artery hypertension, which is risk for anesthesia. But however, large VST in the childhood also, they can present with the congestive cardiac failure and gross chamber enlargement and recurrent endocarditis, failure to thrive, and recurrent respiratory tract infection. Again, you can see how the change in VST hemodynamic occur based on their size. Small, medium size AST, even if the medium size have a gradient of 20 millimeter mercury, there is no change in PVR and the right ventricular pressure. So they doesn't cause much harm during your anesthesia management. But you have to be careful regarding the large and very large AST, VST, which have right to left shunt, because there is changes in the pulmonary vascular resistance to very high, and sometimes they may develop Eisenmenger syndrome, reversal of the shunt, and there is gross increase in the right ventricular pressure. So these are the child who need special attention. So again, coming to the X-ray, small defects, they appear normal. So large defect, they varied cardiomegaly depending upon the size of the shunt. So this is a perimembranous AST, and this is a transesophageal echocardiographic view. We can, the color Doppler can say left to right shunt flow. And most of the children with VST, they mostly undergo a cath procedure. And in this, you can see all the chamber saturation and the pressure. So what is more important, again, you can see the pressure of the pulmonary circulation. So this is important, excuse me, because there is some degree of the pulmonary vascular changes because the high flow volume. Again, in the cath data, what is more important is the resistance ratio between pulmonary to systemic vascular resistance. If it is more than 0.8, then that means you have to be careful. Similarly, QP-QS ratio, more than 3.5:1, you have to be careful during your intraoperative management. And what are the surgical procedure basically the child undergoes during the management of these defects? If you can see the chart, there are n number of procedure the child can undergo. But however, the common one are cleft lip palate, phimosis, paraphymosis, these are small surgery, hernia, hydrocele, posterior urethral valve, intersusception, esophageal atresia, Hirschsprung disease, and infantile hypertrophic pyloric stenosis, as well as congenital diaphragmatic hernia. So these are the, there are some patients, they undergo a minor surgery, some have moderately, and some have the undergo major surgery. So children who undergo moderate to major risk surgery, they carry more importance and they need more evaluation. So next, in which hospital one should go for? So this depend upon the disease severity and what surgical procedure the child has to undergo. Small procedure and minimal defect, asymptomatic child, like the child has to undergo a circumcision or umbilical hernia procedure, you can go with the minimal monitoring. So in this case, one can go for any periphery hospital. And in case of emergency correction of the appendix or less complex trauma. But however, if the child has to undergo a complex surgery, intersubcision, and one has to go for a referral center or nearby high specialist center for the management. So coming to the anesthesia management in general, so in the prior period, special emphasis should be given to the associated congenital anomaly and their anesthesia implications such as airway malformation, CNS anomaly, because you see you have done the case and especially the patient with the Edwards syndrome and Patau syndrome, they never come up. In the post-op period, they have delayed recovery and all. So you have to explain the patient parents all these things beforehand. There may be delayed drug effect, especially if there is associated hypothyroidism in case of Down syndrome. So these things should be taken care of. And when come to the cardiac defect, small defect, you should not be worried if it is asymptomatic. But symptomatic last defect, if the defect is of more duration, and if the child is undergoing elective surgery, then you reevaluate the echo and cath depending upon the risk of surgery and depending upon the size of the defect and how symptomatic your child is. But if the child is going emergency surgery, then you have to proceed, but you have to ready to manage any mishap and ready with the emergency drug cut, inotrop and the vasodilator. So it is also important to know if there is any congestive cardiac failure, history of cyanosis, any coexisting illness. And in the examination, especially you have to look for the cardiorespiratory capacity if the child is a bigger child. Investigation, it is a must to know the hemoglobin, ECG, serum electrolyte, X-ray, and echo data. Cath age plus minus depending upon the severity of the disease condition. Review all the information from the cardiological examination and review the recent echo data and the CAT data, also the functional status of the child. Also see and assess if any risk factor is present, like if there is pulmonary artery hypertension. If the child is having cyanosis, that means some reversal of shunt is happening. And your pulse oximeter reading can say this. If there is any history of arrhythmia, that means you have to be more careful during intra-period. And ventricular dysfunction, yes, in chronic disease. Review all the changes of the last cardiac examination. Then you have to estimate the risks. If disease severity is more, they come in the high risk. Otherwise, small to moderate defect, they come in the moderate risk. So this is one of the largest study by Lee et al. Published in Anesthesia, Analgesia. Excuse me. So they have done some 10 cases, mostly AST and BST. They have seen that some 11.7% cardiac respiratory event occurs during the non-cardiac surgery in these children. So you have to plan the treatment of the potential complication in the OR, especially dysarrhythmia, pulmonary artery hypertension, and the ventricular dysfunction can happening. And plan for the postoperative care and always discuss the anesthesia risks with the patient plus parent. What is the fasting guideline? And it is similar to any other case, but the fasting duration should be minimum. And give IV hydration while the child is NPO, because hypovolemia and dehydration can precipitate the shunt fraction. While pre-medicated child, you have to balance between the agitation and depression, cardiovascular depression caused by these drugs. So always avoid the high dose. and do SpO2 monitoring in the more risk patient when you are pre-medicating the child. The usual one is oral midazolam 0.5 to 1 milligram per kg plus oral ketamine 5 to 7 milligram per kg, or you can go for a IM ketamine, glyco and midazolam combination. Antibiotic prophylaxis, there is a controversy on complicated AST and small VST. You don't need, but however, it is needed in perimembranous VST because moderate to severe perimembranous VST, they are very prone for infective endocarditis, especially tricuspid valve endocarditis. And also if the child is having prior history of endocarditis or undergoing any dental procedure. So these are the cases antibiotic prophylaxis is needed. So you have to also know the risk factor affecting the changes in pulmonary vascular resistance and the systemic vascular resistance. Coming to the induction, I personally prefer intravenous induction, and intravenous induction also you can go give if the patient is severely hemodynamic imbalanced or having ventricular failure or pulmonary artery hypertension. And at times, if there is major surgery and child is very compromised, you need to start inotrope if there is instability is there. Inhalation agent, if stable hemodynamic, you can always go for it. There is no harm. So which agent you should choose for, again better, whether it is ketamine, thiopentane, propofol, dexmed or etomidate. And mostly ketamine, fentanyl along with rocurinum or cisatracurum is preferred for small children, and etomidate fentanyl for the big children. You can give glyco and atropine, and scoline does not have any harm. So I always believe that stress of placing an IV line is more preferable to the myocardial depression during inhalation induction. At times, the IV line is difficult. In this case, you can go for a combination of 4 milligram of ketamine with glyco 10 mg per kg and scoline to allow prompt induction and ARA control. Maintain it is again your drug of choice. Sevoflurane, you can give 1 to 2% among the inhalation anesthetic agent. This is the safe because there is less chance of depression and low risk of arrhythmia. Avoid nitric oxide because there is always risk of air bubble and risk of pulmonary artery hypertension. You can always give some air to reduce the FiO2. And certain things you should not do because these things, they increase the left to right shunt and they may cause problem during the intra period in terms of arrhythmia, hemodynamic instability, and congestive cardiac failure if the shunt size is larger. So you should avoid high FiO2, hypocapnia, respiratory alkalosis, low hematocrit, and vasodilator because all these things, they decrease the PVR when the shunt is left to right and they increase the shunt fraction. Similarly, if you increase the SBR with light plane of anesthesia, vasoconstrictor, hypothermia, hypovolemia, stress, they can again increase the shunt fraction. Monitoring depends upon the procedure you are doing. NIBP, pulse ox, ECG, and ETCO2 are the usual one. BC is a must in everything, and you can go for urine output and temperature monitoring, and blood pressure, invasive blood pressure monitoring is again done. Excuse me. If there is major surgery, similarly in the massive surgery, you can go for echo, cardiac output, PVR, SBR, and stroke volume variation monitoring. So you should not give, and you should avoid air bubble entry to the circulation, optimize oxygen delivery, optimize the ventricular function, avoid hypovolemia. All these things, they decrease left to right shunt. And air bubble, how to avoid, all of you know, so I'm not going to discuss about it. And always give controlled ventilation. It should be optimal and guarded. And the ideal tidal volume correspond to the FRC to obtain the PaCO2. You can see low tidal volume, it causes the hypercarbia and atelectasis. All these things, they increase the PVR. And high tidal volume, there is a large extraalveolar vessel, they are much compressed, there is increase in the pulmonary vascular resistance. Excuse me. Regarding intraoperative fluid, you can give isotonic crystalloid, colloid, or blood. Fluid bolus 20 ml per kg according to the clinical state. For a full laparotomy, you can give 40 to 60 ml per kg, usually required. And transfusion, you can give if the blood volume decreases or hematocrit decreases low down to 30. And central neuroaxial blockade have a role, but it has a merit by decrease in SPR. But excessive vasodilatation may cause a profound fall in SPR, and this can reverse the shunt. So one has to be experienced while using central neuroaxial block. If the child is having Eisenmenger syndrome, again prevent the arrhythmia and prevent further increase in right to left shunt, avoid hypovolemia, and avoid the increase in the PVR and decrease in the SVR, give antibiotic prophylaxis, prevent the thrombosis, and optimize the coagulation status of the child. And during the post-op period, adequate pain relief is important because inadequate pain relief can give rise to agitation. Again, the shunt disturbance can occur, and the child has to back to the ward when fully awake, warm, and pain-free. And avoid any respiratory depression, and use regional analgesia whenever it's possible. Maintenance fluid, again, you can use holiday Segar 4:1 formula with 5% dextrose and 0.9% normal saline. Regarding the analgesic, you can go for IV opioid, ketamine, and local anesthesia for the best pain relief, or you can go for simple analgesic as well in form of the ketorolac and tramadol. NSAID, they are effective, but they precipitate renal failure in a child with severe dehydration. So paracetamol is a better choice in these cases, and one can go for regional anesthesia whenever it is possible. So we can go for a few cases. And the first child is 1 year, 3-month-old baby, and this child has undergone post-cleft lip repair at the age of 4 months, and other history was not available. And clinically, he has symptom of failure to thrive and recurrent URTI. And clinically, he was diagnosed to have some heart defect, and an echo examination was done. There was perimembranous VST of size 5 millimeter, left to right shunt. There was mild cardiomegaly on X-ray, and QPQS was 1.8:1 in the cath. So this is the moderate size of the AST. So cardiologist opinion was taken. They want to wait till 2 years of age because most of the time 5 mm AST they close spontaneously. So in this case, anesthesia is low to moderate risk, and Emla cream was applied for the IV line, and GA was this child was very uncooperative, so we had given GA with the air oxygen sevoflurane and later monitor with the midazolam and fentanyl, and basic monitoring was done for this case, including temperature monitoring. And this child developed intrabronchospasm in spite of the adequate plane of anesthesia. BIS was 40 to 50, and he was treated with hydrocortisone 1 milligram and derifylline 2 milligram per kg. Bilateral zygomatic maxillary block was given for post-operative analgesia. This child was extubated on the table and on eventful recovery. And the second case, this I had done a couple of months back in aortic cardiac. This child was a 12-year-old with perimembranous VST and with Eisenmenger syndrome, came for mediastinal mass surgery. The child was on sildenafil, bosentan, and nitrate. So we had given antibiotic. This child doesn't have any congenital anomaly. So antibiotic prophylaxis was given because this is a high-risk case. And all the monitoring, including central venous line monitoring, was given like cardiac patient. The surgery lasted for 5 hours. There was 2 liters of the blood loss in this child. Excuse me. So this child have 2 episodes of SVT. And treated with esmolol. Excuse me. There was optimization of the volume and ventilation. Multimodal analgesia was given with paracetamol block, ropivacaine. IV fentanyl was given for the day 1, the first day only till the evening, and later on he was managed with ketorolac and tramadol. He was extubated on the 5th hour post-operative period. And the next case came in emergency is a 4-month-old baby with a history of interception confirmed with X-ray. And this child was having recurrent URTI, however, ignored by the parents, and he was taking some Ayurvedic medicine. There on examination, there was suspicion of the heart defect, and he on the echo, he has a 7 mm perimembranous VST. There is evidence of right and left ventricular enlargement. So what about the anesthesia management? So then in this case, don't hesitate to consult your cardiac colleague. So in this case, you have to be really careful, because the size of the VST is large and the patient is symptomatic, and these are the child who are more prone, and surgery is also emergency, and it is a major surgery. So you have to prepare to prevent any arrhythmia, heart failure, and ventricular dysfunction, as well as pulmonary hypertension during the intraoperative period. And next case is again 15-year-old waiting for surgery, obstructed right side inguinal hernia repair. And he doesn't have any history of orthopnea, PND, or palpitation. And he was on a regular injection of benzathine penicillin with metoprolol because he has history of atrial fibrillation. And but however, examination doesn't reveal any much abnormality. And there was grade 3 pansystolic murmur. There was no evidence of pulmonary arterial hypertension, congestive cardiac failure. And there was a 20 mm huge AST, and there was increase in the right-sided pressure. The pulmonary artery pressure systolic was 30 millimeter of mercury. So in this case, one has to ready with all emergency drugs, and especially ADR NORAD, amiodarone for any intraarrhythmia, and keep external defib pad ready with external defibrillator, and ready for any emergency tracheal intubation. And these are the child, because this is emergency, aspiration prophylaxis is a must. Antibiotic prophylaxis again is a must, because you're handling the gut. Again, the size of AST is very big, and there is some evidence of the pulmonary artery hypertension. If the child and parent agree for epidural anesthesia, this is a bigger child, one can go for it, but you have to prepare for emergency tracheal intubation in such cases. Monitoring is again little bit more monitoring. If it is available, CVP and IVP, you can go for it, and you have to prepare for any intra adverse event. So coming to the conclusion, so child with left to right side should not be taken too lightly, and not too seriously also, because at times small son too, you have to, some people become very serious, go for a n number of investigation. That should not happen. Similarly, if you have done couple of cases and if you are very confident also, at times you ignore something, and that also should not happen, because at times this child deteriorate in the month of 6 months also, 3 months also. Once the size is more and cubic EOS ratio is more than 2, then one has to be careful, because these progress very fast and they land up in so much of intra problem. But otherwise, it is not that serious. So proper planning, adequate knowledge is always essential, and always prepare for the emergency. And there is no harm to ask for a consultation from your cardiac colleague. So thank you so much. Sorry for my bad throat, can't help.
That's fine, Minati. And I think we should thank you for, despite your not being well, you actually did our lecture. And I think
running fever also last 3 days.
Yeah, it is. I mean, everybody is, the COVID is spreading, and I think you should take care. Thank you very much. Jody?
Yeah, definitely. Thanks, Dr. Minati. Thank you for plowing through this in spite of your challenges. I mean, it's I thought we would at least can keep the cases to the end, but you finished quickly, so that's fine. That's great. Thank you very much. Just to see if they have any questions from other panel members. I don't have any questions. Shiv, you're muted.
No, there isn't any questions as such, but there is actually a comment by Dr. Hemant. In the chat, he said the left to right shunt inhalation anesthetic agent act faster, and in right to left shunt intravenous agent acts faster.
In my personal opinion, I can say that it's much theoretical. So after doing so many cases, pediatric cases, almost 50% my case are pediatric only. So every day I'm doing one pediatric, one adult. So it is much more of theoretical. During PG days, we used to believe this is happening, but actually since this doesn't happen. The induction time is same as I can say in both the agents.
Is it quite possible with like inhalation agent, depending on what is there? It'll be different for halothane than for acid-desflurane or sevoflurane.
Yeah.
So it may not matter much with sevoflurane, but maybe for halothane, maybe, or isoflurane, maybe. But I think that, again, the difference is so small, it's not clinically significant. But yes, I think for postgraduates, I think this question still asked in the exams, and
Yes.
you might still need to put it in if you're actually doing a short answer question or a long question, then you might actually have to mention it just for completion's sake.
Absolutely.
Yeah.
I think Dr. Paliwal has a question. What drug to use for procedural sedation in such patients?
Procedures sedation, we use usually midazolam, dexmed, and little bit of fentanyl or ketamine. Also, these 4 drugs, depending on the personal choice, we are titrating and using. So I have not seen any harm in using any of these agent during the procedure sedation. Mostly cardiac cath lab, CT lab. We are regularly using all these things, but there is no harm in the therapeutic doses, and they do not change much. SBR and PVR and shunt, all of them are equally helpful.
Okay.
I think question always remains about the effect of the anesthetic agent or sedative agents on the pulmonary vascular resistance. So patients who may have a larger shunt and with some evidence of pulmonary hypertension, people will start question, oh, is ketamine okay? Is for that matter, I mean, sedation, reducing your respiratory rate, increasing your maybe PaCO2. So I think those are the kind of questions. But again, a lot more theoretical. Practically, obviously, you will titrate to the patient requirements and you will be monitoring the patient. But again, I think for postgraduates, it's important to actually understand the effect of these agents on the pulmonary vascular resistance.
Absolutely, yeah. I think, yeah, as you said, it's probably the secondary effects of the medications on their oxygenation and CO2 makes a bigger difference than the drug in itself and choice in itself.
Absolutely.
Obviously, the ketamine dexmed has sort of that ability to maintain a better ratio of the ventilation than the depression. So it's a favored choice in very many circumstances. But again, it's the user's comfort in a given drug than the drug in itself.
Exactly.
The reason why this has come from Dr. Naresh Paliwal is because he uses ketamine and dexmedetomidine combinations quite commonly, and I think he just want to have this reassurance that it is a safe combination in these cases.
Yes, yeah, definitely, yeah.
It is a safe combination. Even ketamine in the therapeutic dose, like 2 milligram per kg, doesn't cause any change in SBR and PVR. There are a couple of studies before also, and from our institute also. I was also part of the study, and it doesn't cause much difference. Changes in the hemodynamic in case of the shunt.
I think in India, I think dexmedetomidine is very easily available, and so is ketamine. So I think
Yes.
having these 2 drugs and using the combination to the advantage, it's, I think, a great combination. Any other questions or any other point? I don't see any other. Do you? Right. So there's one question on the group. It says, when do you ask for cardiology consultation in left to right shunt?
First of all, when you are uncomfortable, I can say, to manage. That is number one, because I have seen in the initial days from our place also, people used to give left and right cardiological consultation if there is a small murmur. But now they're not giving. If the echo report is available, If the shunt size is less than 5 mm, you need not to worry. And if the child is small, yes. If the duration is longer, there is every chance of Eisenmenger syndrome development and chance of pulmonary vascular resistance increase. So better you can go put a pulse ox also. You can see the saturation in the room air. If it is not acceptable, or you can send for a blood gas also. If it is not acceptable, in that case, you should send for the cardiovascular consultation, and especially if the child has to undergo a major surgery.
Is there a kind of a cutoff point, says what oxygen saturation or what PO2 or anything which?
There is no cut-up limit, but it should not be less than the normal. And patients should not having any other respiratory problem which causes there is the decrease in oxygen saturation. That should not be there. It should purely cardiac, and the saturation should be lower than the accepted value, not accepted normal value.
Okay.
So then in that case, it is a suspicion. And another thing, if the child is having any evidence of the congestive cardiac failure directly coming to you, you just see a murmurs. In that case, definitely you have to go for the entire investigation and evaluation total from the cardiology side. And if the child is having long-standing arterial fibrillation and intermittent cardiology follow-up, and they have said they are waiting and the defect to close, or they are going for the catheter device closure. In that case, if you're uncomfortable, you can go for cardiological consultation if you're in a peripheral unit. But if you're in a central unit, availability with all the drug and monitoring system, in that case, I don't think you should go for a cardiology consultation, because everything is available. All the investigation report are available in your hand. So you have to be prepared with all the emergency drug management of the atrial fibrillation or cardiac failure or PA crisis, whatever is happening in the OT.
Yeah, I mean, one of the issues in India is that a lot of times the ASD get undetected. They're obviously detected during maybe pregnancy is, I think, one of the commonest times.
Yes.
And we've seen lots of cases of presentation of Eisenmenger syndrome during pregnancy. And I think it's late presentation.
Eisenmenger syndrome is a late presentation, and mostly that happen in the small and moderate size long-standing shunt. At times the cardiologists think the shunt will close. At times the patient is as such asymptomatic, they don't, or mildly symptomatic, they don't come for the follow-up, and gradually they don't have any symptom. Once Eisenmenger syndrome develop initial stage, they lost the murmur. That is the first thing. So once they lost the murmur, most of the people, they think the child, the patient has become normal only. The defect must have closed, so they don't go for any other further investigation. So these are the patient, actually the previous AST or VST with large murmur and symptomatic, and all of a sudden stop of the murmur. So that is a obvious sign. Even if they are asymptomatic, you have to check for the Eisenmenger syndrome in that case.
Is there anything specific? I mean, this is obviously a pediatric symposium, but anything in specific you would actually like to talk about in pregnancy, or they're coming for delivery or for cesarean section? The anesthesia.
We can go for pregnant patient with non-cardiac surgery, pregnant for cardiac patient for neuroaxial block. That also we can include for the people. Neuroaxial block is very common in the cardiac patient, and the patient, many patients, they come with corrective surgery also. And many of the corrective surgery, especially, and some are the prophylactic surgery. The child, they do not go for the corrective surgery in the latter case because they are not acceptable for corrective surgery, especially the Fontan and Glen. And so these are the patients that later come in pregnancy, and many people, they give neuroaxial block. So they are the separate entity again. So we can discuss that sometime also.
Yeah. That will do it in the adult, I think, obstetric.
That would be a good talk on both each and every aspect of it, as you said, talking about neuraxial blocks or just to provide how to safely provide a general anesthetic in the face of pregnant women with a significant ASD with or without Eisenmenger's complex.
I have a question here. Can you briefly explain us what your anesthetic technique is for children undergoing cath closures of this left to right shunts?
I think that's for
Like device closures that cath interventions for device closures of ASD, VSD. Do you do anything specific for the anesthesia for these? Any change in techniques?
No, interventional procedure, we don't change much of technique. We go same like mostly IV induction. But if the child is definitely non-cooperative, you go for inhalation. But mostly we go for IV induction with the ketamine and maintenance midazolam fentanyl or dexmedetomidine or propofol depending on your choice. And monitoring again, cath lab, the entire monitoring is done as such. So
Okay,
there is
so
not
you also
much
put
change
an
in
arterial
anesthesia
line.
technique.
Okay, thank you.
Monitoring. I think Senthil was asking whether you do put in arterial lines or invasive monitoring for these
Yes,
patients.
invasive monitoring is a must in the cath lab. All the device closure, there are every propensity for migration of the device, dislodgement. There is any happening in the cath lab as such. There is perforation. There is a misfit of the device. The lab procedure may last from 1 hour to maybe extend to 5 hours. There may be tamponade or anything can happen. So invasive lines, central venous line, and all these lines are must, and including GA. All the device closure we go in GA.
Okay, sounds good. Thank you.
Just to confirm, you would definitely intubate paralyzed for the procedure.
Yes.
Okay.
Will we go on to the next lecture?
Sure.
Yours?
All right. Let's share the screen.
Yep, all visible.
Okay, we're going to change track, and I'm going to talk about anesthesia for craniofacial surgery in infancy. This is probably one of the specialized area of the plastic surgery, which very often in the realm of tertiary or quaternary children's hospital. However, it's important for even general anesthesiologists as well as trainees to understand some basic understanding of the presentation of these patients and some of the surgical techniques involved and in the management, because that will guide them to how to evaluate these patients safely when they come for non-plastic reconstructive surgery. So what I'm going to do in the next 20 minutes or so is to talk about briefly, these are my objectives to pathophysiology of the craniosynostosis, to give you an understanding of the relevant surgical techniques commonly employed in the correction, and describe some of the anesthetic management when these infants undergo full repair of craniosynostosis. So what is the definition of craniosynostosis? Craniosynostosis is a premature fusion of one or more cranial suture. This can occur as an isolated abnormality in an otherwise healthy child, or this could be part of a syndrome. Isolated abnormality is more common. It's probably around 80% of the craniosynostosis you see is isolated abnormalities. And over 20% may have either a labeled craniofacial syndrome or unlabeled craniofacial syndrome. The most common genetic abnormality underlying these syndromic craniosynostosis is the fibroblast growth factor receptor mutation. Normally, the cranial sutures don't fuse, like the metopic shouldn't fuse before 6 to 9 months of age, and the sagittal shouldn't fuse before 22 years of age, and the coronal 24 years of age. These are the normal timeline where these sutures fuse. However, if they fuse premature, this is where you end up with a craniosynostosis. There is a law that helps you to understand the shape of the skull that result from this premature fusion. It's called as Virchow's law. So like in this diagram, the first one, you can see the red line is where this suture is fused. This is a sagittal synostosis. The law states that when the fusion results, the cranial growth is predominantly parallel to the suture lines, which means the growth of the skull is going to be in the anterior-posterior direction and is very restricted in the lateral direction. So you end up with a boat-like skull. Similarly, in a metopic synostosis, which is the fusion of the metopic suture, you're going to get a more anterior bossing of the frontal table. And you end up with what you call a trigonocephaly. In a coronal synostosis, what happens is you get a fusion of the coronal suture. So the skull is going to be broader in this orientation, and it's going to be very narrow in the anterior posterior orientation. This ends up with something called brachycephaly. And this is just a further illustration of the same concept. For example, the figure on the left side of the screen is scaphocephaly from sagittal synostosis. The red line is this fused sagittal synostosis, restricting the lateral growth of the table and causing more of an anterior posterior growth. And here you can see the metopic synostosis causing more of a triangular shaped head. As I said, 80% of the synostoses are simple. However, 20% do have syndromic association. And if you look at the books, they will talk about over 100 syndromes can be associated with canine synostosis. But the common ones are Apert, Crouzon's, Pfeiffer, Seythry-Kotzen, and Noenkey syndrome. Why do we need to know about the syndromic canal synostosis? So very often these syndromic ones not only are associated with multiple cranial suture line fusion, but they also have extra skull deformity that includes a mid-face hyperplasia. They may have a shallow orbit causing something called as exorbitism, which means that there is a shallow orbit and you end up with a proptosis with a significant chance of injury to the eye or to the cornea. They could have other associated anomalies such as cleft palate, corneal atresia, congenital heart defects, high ICP, and to complicate the matter, they may also have syndactyly, making IV access extremely challenging. Besides the secondary effects of having a tight skull and restricting the brain growth, some of these syndromic craniosynostosis are also associated with a primary neurological abnormality, which means that besides their the abnormalities, they can have like something like ventricular megaly or corpus agenesis. So it's not primary, it's not completely just secondary to the effect of the tight skull. The combination of mid-face hyperplasia as well as other syndromic anomalies places some of these children with a very difficult airway, both in terms of induction and airway management, face mask ventilation, as well as intubation. Just as CT representations of some of these common syndromes, as you can see, all these Aperts, Crouzons, Pfeiffers, Seythry-Kotzen, and Noenkey's, you can see the common features is a bicoronal synostosis. You can appreciate some of the orbital dysmorphology and also the mid-face hyperplasia. As I said, the underlying genetic etiology is the fibroblast growth factor receptor mutations, and very commonly FGFR1 or 2 or 3. And there may be other mutations as well, like in Seythry-Kotzen, it's a twist1 mutation. I've listed some of the features of these, and you can refer to any pediatric textbook if you end up with a patient on your table and you want to know about these symptoms. Even most pediatric anesthesists would not remember all the clinical features of these symptoms. However, having access to some resources will help you in evaluating these patients safely and also planning their anesthetic safely. Most of these syndromes have an autosomal dominant inheritance. However, new mutations do occur in unaffected parents. As I said, the secondary consequence of these craniosynostosis is an increase in intracerebral pressure, which can lead to developmental delays, seizures, and also because of the associated shallow orbit, there is a possibility that these patients could present for emergent craniofacial surgeries if there is a threatening vision is being threatened. And then there is always this cosmetic and psychosocial effects of have to live with an abnormal skull shape. Some of these children, as I said, will present with a significant OSA, and that OSA management may have a pathway where they may be needing either a CPAP or further assessment, they may need urgent mandibular distraction techniques or an emergent tracheostomy to stabilize the OSA before subjecting them to a bigger surgery. What are the surgical principles involved in the management of craniosynostosis? The purpose of the surgery is to obviously align the skull to near normal shape so that the brine growth is unimpeded. As you may remember from a pediatric medicine, the brine growth rapidly happens both in the neonatal and in the immediate postnatal period. And 75% of the brine growth is complete by the end of 2 years. So very often this dictates that if there is a pre-existing craniosynostosis, they need to be operated fairly urgently, either in their neonatal period or within their infant state to provide the optimal brine growth. We also want to improve their obstructive sleep apnea, and that surgery may involve a mid-phase advancement. And many of these children go on to come off their CPAP completely and also be able to be decanulated their tracheostomy. In addition, obviously, it provides the psychosocial benefit of having a near normal skull. So when do these children get operated? As I said, ideally, they should be operated before 1 year of age. But operating the neonatal age group poses a significant challenge, especially because they're going to be of a smaller blood volume, and they may not be able to tolerate such major surgeries. However, the bone at that stage is more malleable and more adaptable. So it's sort of a balance between what they can tolerate and how early we can get to them. That factors in very often in deciding when do we do the surgery. It also depends on what are how many sutures are involved and whether there is a high ICP concerns. But sometimes you do have to have emergent surgeries in these cases if there is ICP is very high, or including a shunt surgery may be dictated, or frontoorbital advancement, as I said, if there is a threatening to the eye. What are the common surgical techniques? Without going into much details about the depth of these techniques, these are the 5 commonly employed techniques in the management of craniosynostosis, from the least invasive one being the endoscopic approach, all the way to strip craniectomy, spring-assisted cranioplasty, total bone reconstruction, and a mid-phase advancement. I just want to spend the next couple of minutes to talk about a few of the surgical techniques. It's important to understand these sort of the steps involved in the surgical techniques if you are taking care of these patients, so that you can anticipate what are the critical periods of the surgery when the vigilance has to be tighter in the management of these patients. So the first one is an endoscopic approach, and this is the least invasive one. It's very often done in the first 3 to 4 months of age, and that is a short window they have for this successful outcome. they have a shorter stay. Some of these children may not need an invasive line. The surgery usually is done within a couple of hours, and they could be discharged the next day. They do need a post-op helmet for up to 6 months. However, even though I say that it's a simpler surgery, there is obviously, this is very often done for sagittal synostosis, and the underlying sagittal sinus injury is always a constant risk in these patients. So some places will still recommend arterial line. Here it's the kids, we always place an arterial line for these kids. However, incidence is around 20% of need for blood transfusion in these kids. And having an arterial line helps us to sample and to keep a close eye on the blood pressure during these critical phases. One of the challenges in bringing these children early on their postnatal period is also that they may be in the physiological anemia stage, because usually that happens between 3 to 6 months of age. So we are starting hemoglobin is very often in the probably in their 10 grams per deciliter range. And so they can quickly run into the threshold range of needing a transfusion, even though you want to avoid transfusion. Sometimes you may not be able to avoid it. And also because there's a very limited time to optimize these patients with iron therapy to bump up the hemoglobin. So it's just a representation of what happens in this endoscopic approach. And as I said, this is very often done for single suture sagittal synostosis. They make a tiny little incision in the front of the forehead and one on the back end. And they dissect out a piece of the calvarium. So they make a little nick, and then they use an endoscope just under the table to free up the dura from the table of the skull, and they resect out a piece of the bone under the endoscopic guidance. And then the post-op, they are required to have a helmet therapy. A slight advancement of the similar technique of the endoscopy is the spring-assisted cranioplasty. This involves placement of a couple of springs to keep the edges of that opened sagittal synostotic piece of bone for a period of time. It's usually between somewhere between 6 weeks to 3 months. They keep the spring, and then the springs are taken out. Again, because they don't take out the strip of the bone, it is associated with less blood loss. And it's also a more simpler surgery. On the other spectrum is a complete cranial vault reshaping, which is the most extensive surgery with significant blood loss. This often involves a bicoronal incision where the scalp is dissected off. Depending on the suture line, there may be anterior cranial vault involvement or a posterior vault. Or sometimes it's a total cranial vault where the kids are initially operated supine and then they go prone for a period of time and then supine again. The whole calvarium is sometimes removed in one or several pieces. And they also, if there is a frontoorbital involvement, they do a bandu osteotomy to free up the frontoorbital ridge. And the calvarium is then sectioned into pieces and reshaped and placed back using a plating system. And then the scalp flaps are put in place and the incision is closed. And this a representation of what happens in Apert syndrome, as you can appreciate the midface hypoplasia. And this particular patient required what he called as a frontal orbital advancement, where they dissect out the frontal bone along with the midface as one block. And there is a distractors placed to advance the midface anteriorly. And this is a post-op image of this particular patient. As you can appreciate how this patient's facial profile has improved significantly. This has got a physiological improvement in her obstructive sleep apnea as well. And this is another representation to show how the frontal orbital advancement will provide a better volume for the orbits. As you can appreciate, in the left side of the screen is a metopic synostosis. They dissected out the frontal orbital ridge, and then they, as you can see, this is the shallow sockets, and then they can reshape it and using a plating system. And you can see the widened orbital sockets that can accommodate the orbits better now. So now, having known the common surgical techniques as well as the presentation of these patients, we can list a list of considerations. So I put a list here. This is what would be required when you are presenting, especially with the trainees, if you want to have a case discussion with their faculty, and you want to talk about what are the considerations. So this is what I would list as a consideration for any craniosynostosis surgery. One is a difficult airway. We understand that these patients could have midface hyperplasia. Some of them will have extra skeletal abnormalities that include cervical fusion, short mandible that may add to the difficulty in managing the airway. The obstructive sleep apnea, and this is more common, especially in syndromic craniosynostosis, especially in the full anterior cranial vault or full total cranial reconstruction is associated with massive blood loss. Up to 1 to 2 blood volumes is expected in these cases. And the combination of syndactyly in some of these syndromic craniosynostosis may be affected with a difficult IV access. These patients, because of the propensity of a big blood volume loss, as well as the bigger table exposed to dural sinuses, more prone for venous air embolism. Craniosynostosis is, especially in syndromic, 50% will have a high ICP that needs to be considered in the management of these patients. And some of these patients may have a congenital heart disease, which may need to be evaluated. And they can pose whatever the pre-op challenges and intubation challenges you face is not going to go away at the point of extubation. And so this is going to be something we need to be considered in terms of how we manage the airway at the time of extubation and immediately after, and where you care for this patient. So this will be the list of consideration. With these considerations in mind, we're going to go and assess our patient. We're going to, what are the significant points in our assessment? We obviously want to know what are the suture lines that is involved, what is the planned procedure, is the patient going to be supine or prone, what are the associated syndrome, what that particular syndrome, other cranial manifestation of this syndrome, is this associated with limb abnormalities, is this associated with the cardiac abnormalities, is what you want to know. You need to have a full understanding of the obstructive sleep apnea, what is the symptomatology of it, and what is the stage of the management they are on. Some of these patients may already have a plan in place in terms of nasal CPAP, or they may have already had some midface osteotomies, or as an urgent measure, some of these children's pathway may include an elective tracheostomy. Your airway examination among infants is going to be very challenging. But however, a lateral profile examination is very helpful to look for midface hyperplasia. You're looking for any recessed mandible, short mouth opening, any limitation in their neck flexion extension. Any pediatric murmur in this syndromic, especially in syndromic craniosynostosis, should be evaluated. There are particular reasons for this. Even if they have a small AST or PFO, because of the high risk of venous embolism, air embolism in these children, device closure may be indicated before subjecting them to a major craniofacial surgery. So these murmurs should be evaluated in consultation with a pediatric cardiologist to make the decision whether that patient will benefit from a device closure before you subject them to full craniofacial surgery. When you pre-op assessment, you'll want to look for IV access possibilities, especially in the face of a difficult airway. You won't be in a place where you're doing an inhalation induction in a patient with an extremely challenging IV access, and you don't have an airway and don't have an IV, and you're in a crisis very quickly and very shortly. Most of these, as I said, most of these craniofacial surgeries is very difficult to get away without transfusing. So you need to have blood in the room, at least a couple of units cross-matched. You need to be cautious of premedication with a raised ICP because of the increased propensity for them to to be very somnolent even after mild premedication, and end up with a high ICP, making things worse. A risk communication with the parents, to be frank, with the discussions about the high-risk nature of the surgery in terms of both massive transfusion needs as well as high risk of venous air embolism and potential for cardiovascular collapse intraoperatively or in the postoperative should be communicated well to the parents. In terms of airway management, your pre-op evaluation should guide you what are the challenges you're going to face and how safe it is to do an inhalation induction or intravenous, and how you prepare for intravenous induction. Obviously, intravenous induction has the benefit of rapidly securing the airway in the face of any obstruction. However, as I said, some of these patients will have significant syndactyly, and getting an intravenous in itself will be a challenge. So this is where having expert help is very important in during the induction of these patients. So it's not uncommon for us to have an inhalation induction in the face of a difficult IV access. We'll have a second anesthesiologist to rapidly secure an IV access as the patients go out to sleep with all gadgets lined up, including appropriate sized oral airway and laryngeal mask airway. It's not uncommon for syndromic coronary synestosis to have a difficult mask ventilation and intubation. So some of the techniques very commonly employed in these is inhalation induction followed by securing IV access. And as you deepen the airway, you might need to quickly switch over from a oral airway to a laryngeal mask airway to maintain the airway patency and deepen the plane of anesthetic. Some of the combinations are used includes a video laryngoscope with or without a fiber optic assistance. The surgical techniques very often will dictate whether a nasal tube or oral tube is recommended. Very often we choose a nasal tube because there's better stability and the ability to suture it to the nasal septum as these kids go prone. If they are working on, especially the midface osteotomy, sometimes a oral tube may be indicated. When they have a maxillary osteotomy, there is always a risk to the endotracheal tube with a surgical saw, and you need to be very vigilant to identify early and to promptly inform the surgeon. And you may need to scrub up and do an intubate. You may need to exchange the tube in the middle of the surgery if it happens. So you have to have your backup tube and a video laryngoscope in the room, especially when you're doing a maxillary osteotomy with a nasal tube in place. There is a high risk of this happening. And as I said, some of these patients may need an elective tracheostomy. In terms of monitoring and as well as access, given that a massive blood loss is expected, you want to have adequate access. In an infant, adequate access, what it means is a 2 working good 24 gauge cannula on a good peripheral vein is good enough access for managing these cases. As long as you can give the way I'll look up at these is that to calculate their blood volume. And if I can transfuse half the blood volume in the next 3-4 minutes, if I had a catastrophic hemorrhage, if I have enough access to do that, I'm happy with my access. So that 22 gauge cannula in a saphenous vein, which is functioning well, is a good access for these infant craniofacial cases. Obviously, bigger is better. However, partially working 20 gauge is no good if it's not in a good place and you have resistance and you don't want to be in a situation like that. Routine arterial access, you can say it's mandatory for these cases because you want to have a B2D variation. You need to be vigilant of the different phases of the surgical, whether it's going to be a rapid blood loss, and you need the arterial access in these cases. Do we need a central access? This is probably central specific. We don't place it in our institutions for craniofacial cases. However, we do place it if we are not getting an adequate peripheral access, we could not get a good size cannula in place, we might put a short angiocath in the femoral vein as our primary venous access. In terms of maintaining anesthesia, there's no single recommended technique. Our practice is very often is a volatile anesthetic with a muscle relaxant and intermittent dose of fentanyl. Some of us do use remifentanil, but I find it difficult to run a remi infusion in the face of ongoing blood loss and hypotension. To keep, very often we are not sure whether it's a remifentanil contributing to hypotension. The positioning of the patient has to be very thought out, because some of the surgery is done in supine and some of them in prone position, and you have to have a good padding of all the pressure points. You want to tape your endotracheal tube in a safe manner that sometimes involved using any sticky glues. Here we use something called mastisol or tinkerbenzoin to the tapes and cover them with tegaderm. You want them to stay in place so that they don't get loosened by any prep solution. You need to take a special care in children with significant proptosis like Crouzon's and Pfeiffer syndrome because of their orbital because of their proptosis. They are very prone for any pressure effect. And that also reminds me to mention, whenever you take care of patients with Crouzon's and Pfeiffer syndrome, or any patient with the proptosis, though we assume a recovery position in their, after extubation many times, you need to be careful when you place these children in the recovery position because the dependent eye could have direct pressure effect onto the bed. And there are instances reported in the literature of visual loss from recovering patients in the lateral position. So you need to be extremely careful with that. We place an underbody barrier and lower body barrier. Temperature maintenance is very crucial. And that temperature maintenance is even more significant because you are going to end up in a massive transfusion state. And we all know that hypothermia contributes to coagulopathy. Some of the widely discussed area in the management and the anesthetic management of craniofacial surgery is blood conservation. As I said, anything more than a strip craniectomy will entail probably up to 90% of these kids will need a blood transfusion. So a very, very small number you can get away without a transfusion. The transfusion obviously depends on how long the surgical blood loss is happening. So the duration of surgery and the younger the patient is one of the two cardinal markers people could associate with the need for transfusion. Where does the bleeding happen? It happens from the scalp edges, from the exposed bone. And occasionally there could be a catastrophic hemorrhage from any venous sinuses. So vigilance is extremely key in the management of these cases. As I said, you expect 1/2 to 1 blood volume with a multi-suture and syndromic craniosynostosis. Preoperative iron therapy, if there is a time to optimize this patient, it's a very, very useful technique. If you can bump up the hemoglobin to 130 range, for a strip craniectomy, you can minimize the transfusion. Beyond that, a good surgical technique is very, very important, and epinephrine infiltration, use of bone wax, skin clips, and fibrin tissue are all shown to decrease blood loss in these cases. In terms of what we can do, offer to minimize blood loss is that we can run a tranexamic acid infusion. This has been widely studied in the craniofacial population. The literature is bound with different regimes. One such regime is 15 milligram per kilo bolus, followed by 10 to 15 milligram per kilo per hour. And this is what we commonly use in our center. Some centers have been successful in avoiding transfusion by using a cell saver with a small collection reservoir, along with a preoperative and post-operative use of erythropoietin. However, this is not a common universal practice, and it's very center specific. As I said, the blood loss is related to how young the patient is and how lengthy the surgery is, and how many switches are involved and what is the nature of the surgery. As I stated, the hypothermia can contribute to the coagulopathy, and you want to keep these patients warm from the get-go. And especially when the phase of placing their access could be long and challenging, you want to make sure that you're not unduly exposing the patient and you maintain their temperature at all state. A massive blood loss can be associated with a significant hypercalcemia, hyperkalemia, and metabolic acidosis. This hyperkalemia is transient, but however, because you're rapidly transfusing on a small blood volume patient, you can, even the supernatant plasma has enough high potassium load that it can cause cardiac standstill. And you may need to use emergent calcium administration along with a cardiac resuscitation sometimes. And metabolic acidosis very often is multifactorial, related to the length of the surgery as well as transfusion needs. We covered some of the ICP in the pathophysiology. One of the important thing about high ICP is that obviously you need to be vigilant about it, and the surgeon may ask for some mannitol and mild hyperventilation as they separate the table of the skull from the dura. And very often, clinically, what you find is that when especially in the high ICP situation, is when they take off the table of the skull, you might find that the blood pressure sags a little bit, and you may need to support with either phenylephrine infusion or a norepinephrine infusion to maintain adequate mean arterial pressure. Some of the common clinical challenges we face is what is adequate mean arterial pressure in infants. My sort of understanding of the literature is that any mean arterial pressure between 50 to 55 should provide adequate cerebral perfusion in these patients. And sometimes you find that when your hemoglobin is adequate, your volume filled adequately, however, the blood pressure is sent to be on the softer side, and you may need to artificially support it to counteract some of the negative effect of your anesthetic. Using some vasopressors. It's not uncommon. Small low-dose phenylephrine infusion or norepinephrine infusion to maintain an adequate mean arterial pressure in the face of high ICP. The risk of venous embolism in these patients is potential, but however, it's also real. What is the incidences? It depends on the monitor you use. If you use a precordial Doppler at TOE, you probably will see that it happens all the time, and it's not all of those do cause any clinical hemodynamic effects. However, you find that around 20 to 30% will cause decreased blood pressure, and hypotension is a common sign we employ, or change in your end-tidal CO2 may mark the sign of a venous embolism happening. It happens because, as you can see from the image, the operative side is higher than the level of the heart, and there is big blood loss that's happening. So you could be in a potential related hypovolemic state, and this could contribute to promoting venous embolism in the open dural sinuses, or even through the scalp vein, or through the open bone. The management principles are lowering the head and left lateral positioning and flooding. Obviously, you're going to inform the surgeon. They will be usually prepared to flood the site with some saline, applying bone wax to the edges of the bone. And you may need to start resuscitation, including inotropic support, and sometimes chest compression you may need to be done urgently, along with the use of epinephrine. The incidence of rare, but it does happen, and this is why vigilance is very important in terms of watching your blood pressure and tidal all the time in these cases. When it comes to management of these cases, both for extubation at the end of the case as well as recovering these patients, minimum would be a high dependency unit for observation of these cases. Most of this, even a syndromic craniosynostosis with a total wall, could be extubated on table. What will preclude extubating somebody on the table will be dependent on how the kid behaved during the surgery. What is the degree of post-op airway edema? What was the status of the airway management? How difficult it was? Some of these cases we may elect to keep them ventilated afterwards till they stabilize, especially for FOD3 as well as monoblock procedures, because of significant facial swelling as well as continued blood loss and CSF leak that could happen in these patients. My sort of a gut feeling is that if you are less than a unit blood volume, you could be safely extubated on table, provided the rest of the parameters are point out to be good. In the post-op period, you continue to watch for any bleeding, coagulopathy, and metabolic acidosis. The pain management of these patients, the first 24 is more crucial. It often involves, because of the age of this patient, you may not be able to give non-steroidal intravenous, and especially in the face of coagulopathy and platelet dysfunction. So it comes down to intravenous acetaminophen along with intravenous narcotics. Here we often use intermittent boluses of morphine up to on doses like 50 mics per kilo to maximum of 200 mics per kilo, and then the first half an hour after the extubation of this patient. And occasionally they may need a small morphine infusion, and they need to be kept in a high dependence setting, watching for both the neurovitals as well as for any ongoing blood loss and clotting. Some of these patients could develop cerebral edema or hematomas, so that need to be closely observed. And there could be a CSF leak occasionally, especially with the monoblock procedures. So in summary, craniosynostosis is a premature fusion of one or more cranial sutures. It can be isolated or it can be part of a syndrome. The cranial wall reconstruction, the purpose is to correct to provide more room for the skull, for the brain growth, and also minimize or treat and prevent the rising ICP. And the mid-phase advancement will help to relieve the obstructive sleep apnea, as well as improve the orbital volume to protect the condyle. The main anesthetic challenges we face with these cases include a difficult airway, difficult venous access, risk of massive hemorrhage intraoperatively, risk of venous embolism, and a need for resuscitation, ongoing resuscitation, both in the intraoperative as well as in the postoperative phase. Just an image to show that how some of these cases have a profound, a beautiful enhancement within 10 days after the surgery. Here, this is a child with a Peroban who had a mandibular advancement, and you can already appreciate how the airway is very much improved, and it's no longer looks like a difficult airway, as you can see from this retrographic picture, to near normal looking baby at the end of 10 days. with that, I'll stop my talk. I'll stop sharing, and then I'll answer any questions. Okay, I can see a lot of questions here. Which artery you prefer kids for monitoring? We use radial artery. If we fail with the radial artery, we would go for the femoral artery and use we do have an Arrow has a 22 gauge 5 centimeter line or 7 or 8 centimeter line. That's very often very useful for both the venous axis and arterial axis. Sometimes if you struggle with the peripheral, if you can't get a saphenous line, you may use an ultrasound and go for the femoral vein, or do in a conventional way and place this line. That provides a good access. Do you use a flexometallic tube, cuffed or uncuffed tube? We don't routinely use a flexometallic tube. I don't find it any particular need for it. In terms of cuffed and uncuffed tube, we were traditionally uncuffed tube institution, but lately, in the last, I would say last 3-4 years, we are increasingly using cuffed tubes. Of course, the cuffed tube provides a single attempt in securing the airway, and you can, instead of extending the tube. However, it does create you end up with a smaller size tube, and there is a potential risk for tube occlusion, and that could be a challenging during the case because you don't have access to the airway. So I would say 50% of the world anesthesiology will still use uncuffed, properly sized uncuffed tubes because it provides a better patent error tube than a smaller size cuffed tube. Do you use atropine glycol as a pre-medication and chance of oral secretion may dislodge the tube in prone position? That is definitely a good suggestion. We don't routinely use it. If there's somebody is going prone, adding glycopyrrolate, I don't see a downside to it. Maybe you may face a mild tachycardia with the glyco, but that's very minimal. So I definitely, it is a good suggestion to use a glycopyrrolate. Mastisol. Mastisol is just it's similar to tinbenzoin. It's just a sticky product. We apply tegadermo that tapes to prevent something. I don't know what is the chemical formulation in mastisol. It just is, we use like a glue when we put our IV. We know that some of these patients could be after a maxilling and amla cream can be, sometimes the tegaderm may not stick very well. We place some mastisol rubbed on the skin that makes the thing sticky. Yeah.
So, one question here. You mentioned the risk of venous air embolism. Do you use like a precordial Doppler? That is something that our surgeons here are very fond of.
At sick kids, when I did my fellowship, we used to have at least 1 or 2 anesthesiologists who will place one, and then they will put up the volume on the precordial Doppler and drive the surgeons crazy, and it happens all the time, but you don't end up doing anything about it. So we end up moving away, and I haven't seen it in the last 10 years. I would say I haven't seen any of my colleagues using a precordial Doppler. It indicates there's a thing happening, but it's unless it's associated with hypotension or change in end tidal, you're not going to act on it. When you have a hypotension, it does create a dilemma. What is the cause of this hypotension? Is it a relatively overdose of anesthetic, or is it a hypovolemia because of this hemorrhage that's happening that's difficult to watch because the scalp edges are bleeding all the time, and you may not, everything is getting into the drapes and it's getting soaked. You may not be able to see them, And third potential is venous air embolism. So you are at that point, you're going to treat all the three, assuming all the three is happening, and you're going to treat all the three at the same time. That involves giving bumping up the volume, maybe need a blood transfusion, decreasing anesthetic, and using some presses. Do you find it useful, Senthil? And the precordial Doppler, have you acted on it, and it has helped you differentiate?
No, never no experience. I just put it there to make the surgeons happy.
Happy, okay.
Yeah. I mean, this is in early 90s. I mean, when I was doing post-graduation pediatrics, it was, I don't know whether you guys remember our pediatric surgeon, Meenu Vajpayee. He was 6 foot, a big guy, operating on this little skulls, with breaking it down and putting it, rearranging it. I mean, at that stage, the monitoring we had was just ECG, blood pressure, and I don't think we even had end-tidal CO2 in the pediatric unit. It was just coming in. I mean, end-tidal CO2 monitoring was coming in at that time.
Mm-hmm.
And I don't remember ever actually we losing any patient.
Mm.
But that also brings the question of, especially I'm not talking craniofacial, but your facial surgeries with that kind of a scaffolding with pins and whatnot. How is the analgesia maintained in these children, especially if you're thinking of waking them up?
Yeah, I mean, it is a fine balance when you get to wake them up. You need to be very vigilant. Very often we end up adding a little bit of a dexmedetomidine at the end of the case. Very often, like 0.3 mics per kilo seems to be sort of a nice dose where they are not too oversedated. Oversedation is quite dangerous in this population. 50 to 100 mics per kilo of morphine, and allow them to wake up, emerge on their own without too much of stimulation. Be prepared to dismantle. Some of these equipments can be dismantled emergently. If you need to secure the airway, you need to have your backup equipments in the room all the time. That includes your video laryngoscope. Some of these mid-phase advancement you would not extubate on the table. Sometimes you take them to the ICU, ventilate them overnight. However, you might need to bring them back next day to the operating room where you're extubating them in a more controlled situation. Where you're waited for all the swellings to go down and there's no further transfusion need. So you might still need to bring them back next day to extubate them in the OR more controlled because the ICU may not be a best place to extubate some of these kids. I mean, the pain management is interesting. You'd be surprised these kids will be walking around in the hall, in the corridors in the children's hospital with all these paraphernalia without, as if they are like any other kid. Like it surprises you. In fact, I had more challenges in Lafayette extubation because I gave 1 dose of morphine than inadequate pain management, inadequate analgesia. Very often you find, especially in teenagers when they have this Lafayette surgeries, is that they can obstruct even with a minimal sedation, and then you can quickly end up in a negative pressure pulmonary edema and situation. So you need to be extremely careful there. The pain requirements very often, especially there, you might see even Lafayette, they're taking a bone graft from their hip. When the kids wake up, they complain of pain in the hip. They don't bother anything that's happening in their face at all. So it surprises how minimal is the pain analgesics need. They do need 1 or 2 doses of strong opioids in the immediate post-op. From then on, regular acetaminophen. And if needed, we use in the end studies, the ketorolac is often used. If there's not a significant platelet dysfunction from massive transfusion, you can safely give a non-steroidal for these patients. So that seems to be the combination of dexamethasone and non-steroidal seems to be the best analgesic for these kids, and minimal use of opioids. Yeah, and regional is helpful in some of the situations. We are not a high regional centers. If you're taking a iliac bone graft, a tap block or a quadratus lumbar block, it's probably more beneficial to minimize the pain there, or even surgical infiltration. Yeah, that would be our regime.
Yeah, so in our hospital here, neurosurgeons operate on these kits along with plastic people. And they seem to use a mixture of lidocaine, epinephrine, and triamcinolone for like local infiltration before the incision. And the surgeons seem to have a really good results with that, both in terms of like minimizing blood loss and also pain management in the postoperative period.
Yeah, interesting. Very, very interesting. I think at already, I think they are actually do use perrectal codeine as well, is also as one of the analgesics. I think codeine is, I think, more commonly used in UK than anywhere else.
Yeah, here it's it's both. Yeah, I mean, I think Senthil and Senthil have done a lot of research on the codeine polymorphism and stuff like that. So they will be say, you guys are far behind. That should have been thrown out of the market for a long time ago.
I think black box, isn't it?
It's a polymorphism problem.
In the US, not in the UK.
It is a black box warning, and it is like contraindicated in children and even adolescents with OSA.
Absolutely.
But we also use at times in cardiac patient also.
All right.
If the kids are very irritable, not responding to anything, and at the position we cannot give some drugs, that time in few cases we give parental codeine.
Well, codeine has been part of the cough syrups in India, isn't it? It's really used in cough syrups in India.
Yeah, maybe the population there doesn't have the polymorphism, the extensive metabolized CYP2D6 polymorphism like here. I don't know.
Senthil, I think you should study that population and see, because you may be surprised, right? Like
that's true.
While one population responds better and it's widely available, you don't see that sort of it's difficult to catch the fast metabolizer, but inadequate metabolizer you should be able to appreciate fairly quickly. They don't respond to anything at all, and suddenly they respond to codeine, means it's not there. It'd be interesting. I was about to say that the thing you mentioned about subcutaneous infiltration is a word here, tumescence. Please don't Google what is tumescence. You'll get something something very inappropriate. But however, the tumescence is a plastic surgical term of mix of these local anesthetic hyaluronidase used to for subcutaneous infiltration before. Even some of the burn surgeons use it for before harvesting to minimize bleeding on the donor site. Yeah, it's very, very effective.
My experience with bone graft site pain has been that infiltration by surgeons doesn't work, but posterior tap, I mean, does actually give very good results.
Yeah.
So, and
I meant as a skin graft. I meant as skin grafting for burns.
Okay. Okay, shall we move on to the next? I don't see any more questions on Facebook or on the YouTube live, so I think we can move on to your next talk, Johnny.
Yeah, sure.
Sounds good.
Yeah.
I'll share my screen here in just a minute. Okay. Are you able to see my screen?
Yep.
Yes, we can.
Okay. All right. It's really good to meet all of you this new year. And thank you, Shiv sir, JD sir, and Minty ma'am for this opportunity. My topic today will be enhanced recovery after surgery in pediatrics. And I'll specifically focus on the pectus excavatum protocol that we use here in our center, and posterior spine fusion for idiopathic adolescent scoliosis. They are very similar, 90% overlap, except for very few differences. And the same could be extrapolated to other surgical populations as well, like major abdominal and major urology reconstructive procedures. So I do not have any conflicts of interest to disclose. Objectives of this lecture will be to define ERAS and to discuss the role of ERAS in pediatric surgery. We'll also talk about the importance of multimodal analgesia in enhanced recovery protocols and talk about the components specific to pectus excavatum and PSF procedures, and a little bit about the scientific background and rationale for things that we use in our ERAS protocols. And we'll finish up with some tips to implement, successfully implement ERAS protocol in a pediatric setting. So this gentleman here is Dr. Henrik Kjellet. He is a Danish surgeon, and he's widely regarded as a father figure in enhanced recovery protocols. He did a lot of work on his adult surgical population and initially published a cohort of patients requiring sigmoidectomy, where he was able to achieve a length of stay of 2 days, which was very significant back in 1995. So enhanced recovery after surgery is defined as a multimodal, multidisciplinary, evidence-based system of perioperative care to achieve early recovery after major surgeries. And we achieve this by multiple steps to attenuate the body's profound stress response to the surgery. So surgery is a major trauma, and no surprise, there is an immense stress response to the surgery, and the magnitude of the response is roughly proportionate to the magnitude of the surgery. The first and foremost is the neurohumoral response, which involves the hypothalamic, pituitary, and adrenal axis. This is tightly interconnected with the metabolic response, which is triggered by an increase in the levels of counter-regulatory hormones, the main ones being cortisol, glucagon, epinephrine, and growth hormone. They together create an environment of hyperglycemia, which results from gluconeogenesis and glycogenolysis, or protein breakdown. This also includes loss of muscle mass as part of the protein breakdown. And of course, there is activation of cellular and humoral immune responses, which goes hand in hand with the hematological response, where the balance is tipped towards a prothrombotic state. So for these are kind of the physiological stress responses to surgery. Apart from this, surgery is also associated with tremendous emotional, psychological, and socioeconomic stress, both for the patient and the family. We almost always see anxiety and depression around surgery, especially in adolescents. And there's also universally concerns about the cost of the healthcare. So if you're able to counter these issues, it would be ideal both for the healthcare system as well as the patient and the family. Enhanced recovery protocols are designed to address these by decreasing stress, decreasing the length of hospital stay, improving quality of recovery, and improving patient and family satisfaction. Can be broadly divided to preoperative, intraoperative, and postoperative components. And preoperatively, the most important thing is counseling to kind of set the expectations for the patient and the family in terms of what to expect, what challenges to look forward to after the surgery. And they're usually less anxious if they know that we have a comprehensive plan in place to kind of help them overcome these challenges. And number of items here are kind of specific to adult world, where the fluid and carbohydrate loading, things like that are aimed at countering the metabolic response to surgery. One thing that's very important in pediatric anesthesia is to minimize the duration of fasting in the preoperative period. Intraoperatively, using short-acting agents to fasten wake-up process, and also using regional modalities as part of a multimodal analgesia is extremely important. And apart from this, conservative fluid management and normothermia are also important. Postoperatively, again, multimodal analgesia, regional analgesia, early mobilization of the patient, early return of bowel function, and thereby ability to start the patient on enteral nutrition, all improve patient's sense of well-being and also decrease the hospital length of stay. So moving on to multimodal analgesia. So multimodal analgesia lies at the core of any kind of ERAS protocol, and this is one area that we as anesthesiologists could significantly contribute to. This is defined as a systemic administration of 2 or more drugs that are combined in a way that they block pain perception at various different locations along the pain pathway, either peripherally or in the central neuraxis. The combination could be additive or supra-additive or synergistic to achieve clinically required analgesia, and also minimizing the significant side effects associated with high dose of a single medication such as an opioid analgesic. This is primarily aimed to move away from reliance on opioid as the sole analgesic agent. This holds extreme importance because pain can through multiple pathways impair patient recovery and contribute to the physiological and psychosocial stress that's associated with the surgery. It increases opioid use, thereby leading to sedation, respiratory depression, and delay in bowel motility. This in turn increases your length of hospital stay. Impaired mobility because of pain can predispose the patient to venous thromboembolism, delayed wound healing, and delayed gut motility. Respiratory restriction, especially in abdominal surgeries, due to pain, can cause impaired oxygenation, increased chances of pneumonia, and delayed wound healing, which again increase the hospital length of stay. And of course, it causes patient and families suffering and poor satisfaction. So a multimodal analgesia kind of addresses all of these issues. And the final common pathway is to decrease the length of stay and improve patient satisfaction. And of course, inadequate treatment of acute pain in the perioperative period can lead to an increased chances of chronic pain and chronic opioid use in the long term. It's not entirely sure if acute pain management contributes at all to chronic post-surgical pain, but this is definitely something we need to do. Even there is a little bit chance of minimizing chronic post-surgical pain. So ERAS tries to limit intraoperative and postoperative opioid use because of all the common side effects that we are aware of. And apart from those, there is also an increased chance of opioid hyperalgesia with a sole dependence on opioid as the postoperative analgesics. And also tolerance and early dependence is very common in adolescents undergoing surgery. So medical use of opioids in adolescents acts as kind of a gateway for chronic opioid use and misuse. And And this is kind of a major topic here, the opioid crisis or the opioid epidemic. And huge volume of studies are going on in this regard to identify the risk factors and limit them. Currently, there is no solid evidence supporting the impact of ERAS programs on the incidence of chronic pain and chronic opioid use. But despite contradictory data, the greater weight of evidence suggests that chronic pain can be minimized or prevented, at least to some extent, by aggressive analgesic multimodal approach in the perioperative period. I'm pretty sure everybody is aware of this. We always try to do like local regional analgesia, non-systemic analgesic modalities as a baseline pain control technique. And on top of this, add a bunch of different systemic non-opioid analgesics that act at different parts of the pain pathway. And systemic opioids are really only used as PRN medications on an as-needed basis. Moving on to the role of ERAS in pediatrics. ERAS was primarily started in adults, and this was expanded to other procedures apart from just abdominal colorectal surgeries. And pediatric world has been late to jump on the ERAS bandwagon. And currently, there are multiple different procedures in pediatrics that have been protocolized. And in some cases, some of the procedures that previously required the patient to stay in the hospital for a few days are now done on an outpatient basis as ambulatory cases because of knowledge from the ERAS protocols. And there is obviously a number of publications in effective nature of ERAS implementation in pediatric surgery. And this one is especially very interesting because this is an ERAS of neonatal patients undergoing intestinal surgery. I'm not going to go into the depth of this. It is very similar to an adult protocol, but with very minor specific changes specific to neonates. So at our institution, we have protocols for major abdominal surgeries for children over 1 year, for pectus excavatum repair, especially the NUS bar procedures, which are considered to be one of the most painful procedures there is. And for idiopathic adolescent scoliosis kids receiving posterior spine fusion, major urology reconstructive procedures like appendicovesicostomies and major orthopedic procedures. So how are we doing after the implementation of ERAS protocols? So this is a paper that we published from our cohort of spine patients receiving posterior spine fusion. We compared 60 patients that were age and gender matched with 60 historical controls prior to the implementation of the ERAS protocol. And as we could see, the orange line here depicts when we implemented the protocol, and the y-axis is the length of hospital stay. We had a median duration of stay of 3.6 days prior to the implementation of the enhanced recovery protocol for the idiopathic spines, which we were able to reduce to 2.1 days, which means the patients get to go home on day 2 after surgery. And surprisingly, a few of them do extremely well, that they're able to go home on day 1 after a huge posterior spine fusion. It's kind of very incredible to imagine because the level of correction that they receive is pretty dramatic. And with that magnitude of correction, some of these kids, about I would say 10 to 20%, are able to go home on day 1. And The same could be said with the total as needed opioid doses used after surgery. There was a significant decrease in the opioid requirements after the protocol implementation. So what are the specific things that we do for pectus or posterior spine fusion patients? Preoperatively, psychological preparation of the patient and family is extremely important. We find that setting the expectations helps reduce the anxiety levels, and also people know what to expect in the postoperative period, and they are ready to go through the process. They get preoperative acetaminophen, pregabalin, and methadone. Pregabalin here is kind of being controversial here, and we are kind of starting to phase out of prophylactic use of any kind of gabapentinoids, which I'll discuss in a minute here. And intraoperatively, they get a regional modality, which in the pectus patients is the thoracic epidural. They also get a ketamine infusion, steroids, which serves both for nausea, vomiting, and pain control. And we kind of try to minimize opioid use because the patients have already received methadone. They usually do not require a whole lot of opioids in the intraoperative period. And all of them get NSAIDs, ketorolac IV in the intraoperative period. Postoperatively, they also get scheduled muscle spasm relievers. The one we use here is methocarbamol, and they also get ibuprofen and Tylenol, which is scheduled every 6 hours. And before they go home, they get a very comprehensive med calendar teaching, which I'll share in here in a moment. So this is kind of a color-coded calendar that we use, which gives a really good idea for the patient and the family on the discharge medications that they are going to go home with. We have like scheduled medications that they take on around the clock, and they also have like as needed medications. So I live in Indiana, and the state laws do not permit us to dispense opioid medications for more than a week. And we hardly ever see any patients requiring opioids for more than a week. And they also get diazepam, which is a central acting anxiolytic and muscle relaxer in case they have spasm causing pain in the postoperative period. So the second most common problem that we encounter apart from pain is bowel motility issues. This causes a significant delay in discharge if the patient has like constipation, nausea, vomiting, and is not able to eat okay after surgery. So we are very aggressive with the bowel regimen. They get Miralax, which is polyethylene glycol, and Docused Senna to help with the bowel motility in the postoperative period. And we'll see in a few slides, they also get naloxegol, which is a peripheral acting opioid antagonist to counter any bowel effect of the opioids that we use. So coming to multimodal analgesia that is specific to an NASPA repair or posterior spine fusion, very similar to other ERAS protocols with a little tweaks in the choice of regional analgesia. And when we talk about regional analgesia, the one that we use in our center is thoracic epidural. And a number of other centers have moved on to use paravertebral blocks and erectrospinal blocks. Bilateral erectrospinal blocks are being extremely popular. A number of centers that I know use bilateral erectrospinal blocks with an elastomeric pump, which the patient can go home with. Sometimes intercostal nerve blocks are also performed. Other things to consider: PEX 1-2 block, serratus block, and expiral wound infiltration in the Ravitch procedure. which does not involve placement of bars. It is extremely painful in the initial couple of days compared to the NUS bar, but then it's much faster recovery, and it's not usually associated with long-term pain like the NUS bars do. And recent addition in our setting is that a few surgeons have started doing cryoablation for NUS bar repairs, which seems to be doing a very good job in postoperative analgesia. So it takes about 12 to 24 hours for the cryoablation effect to set in. And these patients do not receive thoracic epidural. They get kind of an abbreviated ERAS, since most of these patients are able to go home on post-op day 1 after the surgery. We do not have any long-term data on the effect of cryoablation, especially in the prevention of chronic pain. So talking about thoracic epidural analgesia, the dermatomal coverage usually required is between T4 to T6. So we place an epidural at T4-5 or T5-6, which stays in place for 2 days usually, and sometimes until post-op day 3. We use a continuous ropivacaine infusion, 0.2% at about 0.4 to 0.5 milligrams per kilograms per hour. Additives can be used like clonidine or opioids. We do not use any additives here since we have a continuous infusion going around the clock. Benefits of thoracic epidural analgesia. Superior analgesia compared to other systemic analgesics, decreased mortality, and also morbidity benefits in terms of decreased incidence of venous thromboembolism, decreased transfusion requirements in the intraoperative period, decreased incidence of pneumonia in the postoperative period, a lower rate of respiratory depression that's associated with opioid use, and decreased myocardial infarction. This is from adult data. And also decreased chances of renal failure, atrial fibrillation, supraventricular tachycardia, and better pain control helps in the early participation with physical therapy and incentive spirometry, thereby decreasing chances of atelectasis and hypoxia, and also aids early bowel motility and decreases chances of nausea, vomiting. Downsides to using thoracic epidural analgesia, obviously, is arterial hypotension and pruritus in case we add opioids as an additive. There's chances of urinary retention, but it's very less common with the thoracic epidural that we use, especially because it's a T4-5. Motor blockade is not a very pressing concern. Occasionally, we find a few patients that complain motor weakness in the fingers. They're not able to use their remotes. They're not able to play their video games. It's kind of a very common concern that we come across after the patients receive a thoracic epidural. And sometimes we also face technical failures like a one-sided block, in which case we just do like a bolus and resume the infusion. Sometimes this seems to help. Chances of epidural hematoma extremely rare, about 1 in 168,000. Infection, about 1 in 145,000. And persistent transient neurological injury is also very uncommon, about 1 in 200,000. So coming to the systemic analgesic adjuvants that we use. As we talked about the preoperative period, we use Tylenol, methadone, and pregabalin. Methadone is continued into the postoperative period. We do this every 12 hours. We use a dose of 0.1 milligram per kilo, and we max it out at 5 milligrams. Some places do like 0.2, 0.3 milligrams per kilo. But given the long duration of action of methadone, we are always concerned about delayed respiratory depression. So we limit ourselves to 5 milligram doses. And they also receive methocarbamol, ketorolac, and ondansetron, which are scheduled. And they have opioids available in case they need it, morphine or Dilaudid. And they also have diazepam available in case the pain is more spastic in nature. And they get started on oral oxycodone on day 1, which helps us to kind of bridge the gap for the epidural removal, which is usually like day 1 or day 2. And they are also started on naloxegol, which is the peripherally acting opioid antagonist to prevent opioid-induced constipation. Once they are able to comfortably tolerate oral diet, they are moved to a completely oral regimen. All of these medications could be converted to pills or liquids, whichever the patients prefer. They moved on to oral ibuprofen from ketorolac. And sometimes they still have some constipation even on day 2 after surgery. And in these cases, we use subcutaneous methyl naltrexone, which is again another peripherally acting opioid antagonist. So looking at the specific components and the literature behind the effectiveness of their use, gabapentin 600 milligrams or pregabalin 150 milligrams are a decent dose to start gabapentinoids if we are to use them prophylactically. They are primarily anticonvulsants with some neuromodulator property. These agents inhibit presynaptic voltage-gated calcium channels in the dorsal root ganglion and the spinal cord, thereby decreasing the release of excitatory neurotransmitters. They can cause sedation and respiratory depression, and they are known to be opioid sparing, but there was a recent large meta-analysis that compared around 280 clinical trials with a total N of about 25,000 participants, in which they found no significant analgesic effect in the perioperative period, nor did they find any beneficial effect on chronic pain prevention. However, the risk of adverse events was greater, more than the benefits, and as such, they do not support routine prophylactic use of gabapentinoids. So this is the reason behind why we are considering to remove pregabalin from our ERAS protocol. Moving on to methadone. Methadone is a long-acting synthetic opioid with an elimination half-life of about 24 to 36 hours. It is primarily a mu opioid antagonist, but also has some kappa and delta activity. Apart from the opioid action, methadone has a pretty significant NMDA antagonist action, very similar to ketamine and as potent as ketamine. And it is also a serotonin norepinephrine reuptake inhibitor. So these non-opioid pharmacology of methadone helps minimize opioid tolerance and also minimizes dependence and habit-forming properties with the methadone use. There is no significant opioid-induced hyperalgesia with methadone use like we see in remifentanil. We use a dose of 0.1 milligram per kilo up to 5 milligrams, which is repeated every 12 hours on postoperative day 1, on the day of surgery and postoperative day 1, after which the patient is moved on to oxycodone. Adverse effects include sedation. We come across an occasional patient that is like extremely sensitive to methadone. And very rarely these kids have respiratory depression because we use such a small dose. One thing that is specific to methadone is the QT prolongation. It is a very interesting side effect of methadone that is very specific to that. But this has not been a problem for us because this is concern in chronic methadone use, especially in use for opioid abuse disorders. Methadone has shown opioid sparing in multiple studies. There are these two large meta-analyses, each including about 500 to 600 patients, showing reduced postoperative pain scores with methadone use and also decreased postoperative opioid consumption and better patient satisfaction. However, there is no mention of any effect on chronic pain prevention due to intraoperative and perioperative methadone use. Moving on to other systemic adjuvants that we use here. Non-steroidal anti-inflammatory drugs are primarily cyclooxygenase 1 and 2 inhibitors. They decrease prostaglandin synthesis and prevent peripheral sensitization. Cyclooxygenase 1 is constitutive and is very important for gastric mucosal protection, platelet function, and also renal function. Cyclooxygenase 2 is induced by trauma and pain. So this is what we want to get at, but since the traditional NSAIDs are non-specific, we also get the COX-1 inhibited, resulting in chances of GI bleeding and renal failure. But this should not be a problem in short-term perioperative use. If this is a concern, we go with COX-2 selective inhibitors, COXIPs. But with the COXIPs, there is a risk of stroke and other thromboembolic complications, especially in adults. We do not have any literature of increased risk in pediatric population. Acetaminophen is a CNS COX-3 inhibitor with central pain modulation and antipyretic properties. So a combination of acetaminophen and NSAIDs is considered to be supraadditive or synergistic. Other main agent that we use is muscle relaxers, since with the pectus bar repairs at least, the incision is quite tiny. It's about 1 to 2 inches on either side. It is a minimally invasive procedure. And the main pain is from the NUS bar or the pectus bar that is kind of distracting the chest wall. And the change in configuration causes a lot of muscle spasm around the NUS bars. And methocarbamol is the agent that we use here and is extremely helpful to address this muscle spasm. So there is no level 1 evidence that supports the use of muscle relaxers for perioperative analgesic efficacy. It is more anecdotal in our institution, and I'm pretty sure many other institutions around the country use this. The other agents that are used include cyclobenzaprine and tizanidine. We dose methocarbamol at 10 milligrams per kilogram, and we could go up to 15 milligrams per kilogram. One thing to notice is you should be aware of IV preparation. It is kind of contraindicated in renal impairment because of the additive that is used, polyethylene glycol. It's contraindicated in renal failure. The mechanism of action of methocarbamol is not entirely clear. It is possible that it has CNS action, and this is why it causes mild sedation. It's not a strong sedative like Valium or opioids, but still could be associated with some sedation. And it could possibly act on spinal motor neurons as well. The other class of muscle relaxers that we use include benzodiazepines. These are GABA agonists in the central nervous system. They have anxiolytic property, sedative property, and also antispasmodic. The dose that we use here for diazepam is 0.1 milligram per kilo. Usually max it out at 2 to 5 milligrams to avoid excessive sedation. And this is available as needed, and it's not scheduled around the clock. Other things that we use, NMDA antagonists, ketamine, it is mainly used intraoperatively, especially with the posterior spine fusion, where neuromonitoring requires a total intravenous anesthetic. We use infusion of propofol, ketamine, and remifentanil, and try not to use any inhalation agents for neuromonitoring. Downsides of using ketamine, it's hallucinogenic and psychomimetic properties, but it's a great agent to prevent opioid-induced hyperalgesia, especially when coupled with remifentanil infusion. And maybe it also has some protective action against chronic pain, but again, there's no concrete evidence to support this. Alpha-2 agonists, clonidine, dexmedetomidine, can be used. They serve analgesia. They're good sedative agents and also have some anxiolytic properties. The downside is their hemodynamic property. IV lidocaine can be used. There's a lot of literature supporting use of IV lidocaine for pain control, but here at our institution, we do not use this. And IV corticosteroids, helpful in preventing postoperative nausea, vomiting, and also has analgesic action. The downside to using ondansetron is QT prolongation, especially when combined with methadone, which also is a agent that could cause QT prolongation. We are extremely careful about this. In fact, on postoperative day 1, patients receive an EKG to make sure that the combination does not cause any significant QT prolongation. And of course, we are very much on top of our bowel regimen with the use of naloxone and methyl naltrexone alongside Docusat, Senna, and Miralax. Opioids are only used as a last resort, PRN agents. The most commonly used opioid, if required, IV is hydromorphone in adolescent patients. And in smaller kids, we preferentially use morphine. When they are tolerating oral diet, they are moved on to oxycodone, which is initially started as scheduled and then moved on to PRN again when they go home. Starting dose for oxy or hydrocodone is about 0.1 to 0.2 milligrams per kilograms, and usually topped at 5 milligrams. Oxycodone helps us to kind of keep the patient covered from pain perspective when the epidural is removed. And the reason for this pain regimen is the idea that the maximal post-surgical pain is in the first 3 postoperative days, the first 72 hours, when we require the maximal coverage. So the patients have an epidural during this period, and both posterior spine fusion and the Nussbaum repair have a significant spastic component that causes pain, apart from the somatic pain caused by the incision and the trauma itself. So they have a scheduled methocarbamol as well as Valium to kind of address this issue. Since the patients are encouraged to move out of bed and to take part in physical therapy and incentive spirometry on post-op day 1, they receive the maximum amount of stuff on post-op day 1. And after this, the methadone drops off on the schedule when they are started on oxycodone. This kind of bridges the gap between methadone and the epidural removal. And all this happened in the background of scheduled NSAIDs and acetaminophen. So there was this paper, it is in pediatric population in the same NUSPAR repair, where the authors found a multimodal analgesia with methadone to be superior to just an epidural-based analgesia without the other systemic components. So this has been very similar to our experience here. We use an epidural along with the systemic components as well. And this is a very small data from our center here, about 20 patients. And we were able to see a significant decrease in the PR and opioid use, as seen here in orange, compared to what previously used to be before the multimodal protocol was implemented. And the total opioid use also counts in the dose of methadone use. So the first post-op day 0 and 1, the protocol group seems to be higher because of the methadone use that is kind of scheduled on day 0 and day 1. And after this, when the methadone is dropped off the schedule, there is a significant decrease in the PR and opioids that is consumed by the patient. So implementing enhanced recovery and multimodal protocols, initially there was a lot of pushback from the surgeons, and they were not ready to buy in with the idea of discharge on day 1 after a posterior spine fusion. But this is kind of a work in progress, and we need more prospective data to kind of support the things that we do. It's very essential to engage all team members in planning the process and in implementation of the protocol. It requires buy-in from the surgeons, buy-in from the hospital system. And once they're aware that the decrease in hospital stay saves them a lot of money, everybody is very happy to be on board with the protocol. And it also takes a lot of education, both for physicians, for pharmacy staff and nursing staff in preoperative PACU areas, and also bedside nurses to successfully implement this. It is important that we recognize that change is very hard to bring in, and implementation is only the beginning. We need to keep identifying and incorporating best practices in a continual process improvement. This is very essential for successful implementation of enhanced recovery protocols. That's all I have for you, and thank you all for your attention, and I can take questions now.
It was fantastic, Santo. We thoroughly enjoyed your talk. I have like a few questions written down here. I'll just wait for the panel members to go first if anyone has any important
Sure, yeah, thank you.
Yeah. Wonderful talk. I don't think there was any questions as such. I think everybody must have been busy listening to the talk.
Yeah, it was like a new information, I guess, for very many. So
yeah. I mean, we know that we have one of our members who's a cardiac pediatric anesthetist, and he's been using ERAS protocol for cardiac. But I think in general pediatric side, I mean, obviously it's, I think pectus and posterior spinal surgeries are still specialized areas, I think. But
Yeah,
still not,
true.
I think, yeah. So Jody, I think.
Yeah, sure. One of the question I have here, Santil, is about the use of methadone in your spine population. Do you have IV methadone? Is it just oral methadone?
Oral.
We do have IV methadone available. Yeah,
really?
I mean, yeah, we try to use that if required in the intraoperative period, but in the floor, it's oral. Oral is like 20 times cheaper than IV methadone. So yeah, but
the reason I
it is
ask is
available.
that very often in posterior spine fusion patients in the day 1 or day 2, they are obviously it's maybe related to the use of morphine. They are quite ileus and they're nausea and vomiting, so they're not tolerating anything orally, and you're not sure about using any PO pain medication for it. Not sure whether it's going to be effective in the sense, is it getting absorbed? Are they getting the benefit from it? So
Right.
what's your recommendations? I mean, or what is your feel about around the use of pure methadone in the post-op period in spine population as such? When, or is it because you're using less, they're not that nausea, they don't suffer from the similar degree of nausea and vomiting and ileus?
Yeah, that's a great question. So what we used to do previously before the protocols were implemented was that patients were put on PCA opioids, which definitely delayed their recovery for at least like 2 more days than what we are seeing now. And I think that contributed to a whole lot of nausea vomiting issues. Now that we are able to cut down on our opioid use significantly, nausea vomiting is also significantly lower. And they get like scheduled ondansetron for nausea vomiting. And they have like other agents available like Phenergan for breakthrough nausea vomiting. And sometimes if they have a history of motion sickness in the preoperative period, sometimes we choose to put a scopolamine patch in the preoperative period itself, which kind of stays in place for about 72 hours. And this helps with nausea vomiting. So most of these patients are very comfortable to be started on a regular diet on even the evening of surgery, surprisingly. And yeah, so far it's not been a very bad experience. So we're able to comfortably go ahead with oral methadone.
Would you say your chance of you needing an IV methadone? The only reason I'm asking is that we don't have access to IV methadone at all. If we ever thought about going on this sort of a regime, what sort of a backup we need in terms of rescuing ourselves in the face of, I can't give the oral methadone because this kid is still vomiting. And
yeah, I think
your chance of needing an IV is very, very small, you would say?
I think so, yeah. I really don't recall requiring IV methadone in the floors at all.
Okay.
But I think it's a good idea to have IV methadone available as a backup in case we're not able to do oral methadone for patient factors. Agree.
Yeah. Second question is this not related to just primarily your talk, but in terms of, we used to use sort of a mixture of fentanyl with our epidural local anesthetic. And sort of in the last few years, we moved away saying that, okay, what it contributes is more of a side effects rather than improve anesthesia. What's your feel on use of epidural opioids?
Yeah, we don't use opioids mainly because of the side effects that you mentioned, like the pruritus and the patient problems are greater with opioids. And when we are using like a continuous infusion, around the clock infusion of local anesthetic, I don't think there is a pressing need for adding an adjuvant. Adjuvants, I think, are used to like prolong the duration of your epidural drug. But when you're like doing around the clock infusion, you don't have that problem. You have a continuous coverage. So I don't think that's very essential. Yeah. It's Shivsai.
Santil, I think if you look at the way epidurals have been used, we tend to use very low concentration along with opiates. I think the reason is that the low concentration is not going to give you enough analgesia. And the opioids actually help in that. It just improves the quality of analgesia.
Right.
But if you're looking at your group of patients where they actually have, one of the problems is muscle spasm, do you use a higher concentration which might actually cause muscle relaxation or a denser block? Obviously, there are associated problem with hypertension. I think it's a fine balance, isn't it?
Yeah, so that is exactly a primary concern, especially because we are doing a T4, T6 thoracic epidural. We don't want to cause excessive like cardiac sympatholysis, leading to hemodynamic instability. So we find it useful to use the muscle relaxers instead. The other problem with especially the NUS bar repairs is that the bar is going to stay in for like 6 months and the epidural will be out in 2 days. So they are going to have like a prolonged duration of problem with spasm. So we need to like get them on a regimen that is going to stay with them for at least a few weeks after they go home. So
no,
that's
I was just thinking of the initial period. I was just thinking of the initial period when their spasm might be more intense than as they get used to, or the healing process.
Right.
And
that's true.
Is there any studies where they have looked at, erector spinae blocks or thoracic,
Yeah, there are studies where they have successfully used bilateral erector spinae blocks, and even patients go home with like erector spinae catheters. So elastomeric pumps and erector spinae catheters, they have been found very useful. Yeah.
Because one of the advantages of erector spinae block is that obviously does go to the paravertebral area. It's supposed to go through the muscle transfer, but also there is also some local effect on the muscles as well.
Right. Yeah.
So maybe, I mean, has anybody tried to directly compare the muscle spasm in erector spinae versus the thoracic paravertebral or thoracic epicurus?
Yeah, that's a very interesting thought, but I don't know, I'm not aware of comparison in terms of like muscle spasm as an outcome. I haven't come across any of those. It would be a very interesting thing to study. Yeah.
I mean, I don't know how you would quantify the muscle spasm because it's probably based mainly on the patient presentation.
Yeah, it's subjective.
Subjective, very subjective thing, but that's maybe the only problem because studying it, looking at electromyographically or something might not be feasible, but it's something probably. But then I think because your oral muscle relaxants are working so well, I think people may not have gone into so much details about using regional.
Yeah, so now a few surgeons are using like intraoperative cryoablation of the intercostal nerves, like 2 segments or maybe 3 segments on both sides. It prolongs the surgical duration to about 1.5 hours than the conventional. But it seems to be working great. Patients are doing great. They're like really numb, and it stays on for like a few months. We don't have any long-term data on this, but I'm very curious how they turn out.
But if you look at in adults, that has been studied extensively, and one of the issues is pain from regeneration.
Right. Yeah, that's true.
So I don't. Maybe we don't know about children because maybe the way they regenerate or their nerves regenerate might be better than in adults. Maybe in adults it's different.
That's true.
That's again another interesting area to actually look at the long term, whether children tend to develop regeneration pain after
exactly.
paralysis. But in adults it's known fact that it can worsen. It was used for thoracic surgeries, but I think it went out of fashion from adults.
Right. Yeah.
I agree with Senthil. I mean, we come in a full circle with this pectus cases. That used to be a very nightmare scenario for the last before 3-4 years. Until then, we were doing thoracic epidural. Half the time it works, half the time it doesn't work. They are completely, you have a beautiful tramline trends during intra-op, and then the kid wake up in screaming pain in the recovery room. And you wonder like, well, I didn't give you any opioids intra-op, and then what's happening now? And then they have it's signs of sympathectomy on one side, and then they have a dilated, like a mydriatic pupil, and it's definitely working, but but why are you complaining about the pain? Your epidural is working. They are still in pain. So 3-4 years ago, we switched to not doing epidural. We switched to serratus plain blocks and got some opioid and ketorolac and dexamethasone. And suddenly we did not see a problem that, it's not that the pain has gone away. It's more manageable compared to we found ourselves in a situation where we are better able to handle these patients better than the epidural that half the time doesn't work. It's working, but it's not effective for the patient. And now last year or so, we have gone into the cryoablation. That's what we are doing now. So here we don't offer thoracic epidural. It's pre-op placement of bilateral serratus plain blocks plus cryoablation, ketorolac, dexamethasone, and PRN opioids needed. As Senthil said, it's the first 16-18 hours later, they're happy. It's not a problem. Okay. Yeah.
I think the reason why your serratus anterior plain block is actually doing better than epidurals is thoracic epidurals is the reason why I was talking about rectus spinae block. They have got direct effect of local anesthetic on muscles. We know that they are muscle relaxing. They improve the blood circulation. They are vasodilators. They do affect. So there is seepage of local anesthetic, not only obviously blocking the pain, but also actually directly causing muscle relaxation. And that's why I think these peripheral blocks, like rectus spinae or serratus anterior plain block, may be giving a slightly greater advantage than.
Anatomically, it doesn't make big sense because you're putting it in a place when you think the lateral thoracic nerve is already exited or something like that. It's quite close to the surgical incision site, pretty much, where they insert the NUSPA. But it seems to still cover. You think you need to go a little more proximal to the spine, but it seems to be working, and the patients seems to be comfortable better than the epidural. So anyway, that's where we are.
But also, you are using higher concentration of local anesthetic in your blocks than what you use in your epidurals.
Yeah,
that's what the question I actually asked. I said, are you actually using a slightly higher concentration, but at T4, T5, you wouldn't want to use that high concentration and cause blockade and sympatholysis, which is actually be more problematic. So it's I think a balance of things, combination of the oral analgesics, non-opioids, and maybe blocks.
And Senthil's talk about methadone usage is something that we are. Senthil Sadasivam, I don't know, Shiv, the Senthil from Cincinnati. He gave a talk to our department yesterday, and he was presenting the methadone data for us. And that's the biggest talk of the department now is how we can get on to that sort of a protocol for a spine patient. So that's going to be a little game changer for us. I think we are in a comfortable zone now. We do intrathecal and seems to have dropped our discharge days, to 2 days. But it's quite an eye-opening to see the methadone does make a big difference. And he was talking about even not needing an intrathecal if you use methadone. Your first like what Senthil showed in the graph, the first 24 hours is not as good as intrathecal, but it's good enough on methadone, enough for you to continue for another day. And they can, on a better streamlined regime than going up and down with the intrathecal. Yeah, it sounds like a great idea. So wonderful work, Senthil.
Thank you, sir. Thank you for the opportunity.
I think this is one thing which I've been thinking of using even in adult sort of orthopedic cases.
Yeah.
Is methadone, but we have
Sure.
oxycodone. I think oxycodone also works, but I think comparing the two will be great as a methadone. Methadone is, I think, is cheap, but is I think a fantastic drug. But unfortunately, is associated with drug addiction, in a sense that it's usually the drug addicts who are given methadone.
It has that stigma to it. Yeah, it
Stigma,
definitely does.
absolutely. So I think that's where we need to actually change the mind frame of people saying that no, this is another analgesic.
Yeah.
Okay.
I have to thank Minati Madam for her talk in spite of her health issues. Again, it was fantastic, Madam. Thank you very much.
Yeah, thank you, ma'am.
And-
Thank you so much.
Yeah. Okay.
Senthil, again, it's a pleasure
Thank
listening
you,
to you.
Senthil. Yeah,
Yes, sir.
absolutely.
Yeah, thank you, sir. Thank you.
Thank you, Dr. Sieb, Jadi, Senthil.
Jody, you have to thank Jody, not me.
I thank Jadi also.
Yeah, no, I'm very thankful because I need to move on with these cardiac cases and I can't, and I thought, okay, I know Minati Madam already offered to help a long time ago, but at that time we did not know whether she'll be, overqualified to do a simple talk for us. But
I forgot also, and in between, just 3 days before, I saw that because almost every week I'm giving one this thing somewhere.
so many times.
So I saw again only I'm having one more, and that too my throat is so bad, and it should not increase, but it increased.
that's okay, ma'am. You
Okay.
did fantastic.